So this session is going to be focused on Master's approach to critical limb ischemia. And I have an esteemed panel with me here and speakers who are going to enlighten us. And that includes, to my left, Dr. Mehdi Shishehbor, Dr. Arthur Lee, Peter Sukas, Erin Armstrong, Kevin Rogers, Dr. Munir Niazi, and myself, who is going to do the very last talk about some techniques and strategies. Dr. Golzar is not here. Yes. And Dr. Munir is going to do his talk also because he got stuck in Chicago. So without further delay, let me invite my colleague and friend, Dr. Mehdi Shishehbor, to talk about alternate access and why and when.
Thank you very much, Subhash, and thank you all for being here. I know the lunchtime got a little bit crazy, but hopefully we can get back on track again. So this is 1 p.m. Okay, perfect. So I'm going to I'm not going to get into detail because as you can see in this session, we're going to get into the nitty-gritty of each technique for alternative access. So, but I just wanted to highlight why do we need alternative access, and I think we have highlighted this throughout some of the sessions this morning and also yesterday. But just to bring it together and kind of set the stage for my colleagues here on the panel, that why do we need alternative access? You know, this was one of my cases. Actually, this patient came in with acute MI, and we were trying to get in from the groins. Ended up the patient had aortic occlusion. We tried to go from the left radial. It was subclavian was occluded, so we had to go from the right to be able to treat this patient for a non-ST elevation MI. But again, having the capability of being able to gain access in various locations, it really allows us to treat our patients and improve our success rate. But where does that come from? So to highlight that, I went back to the basal trial of critical limb ischemia, try to understand what is the success rate when you just take the antegrade approach. Why do we need retrograde? And as you know, basal trial had 585 patients. Many of them came from 6 centers. Indeed, 61% of the patients came from 6 centers. So they were experienced, right? A significant portion of the patients came from these 6 centers. Among those patients, 34% were excluded because it was felt that they could not be treated. So how about the rest of the patients? Well, it turns out that amongst the rest of the patients, 20% of the patients could not be crossed in an antegrade fashion. So right there, I think I can really stop. Really, that highlights the fact that 20% of the time, when you have experts trying to cross these lesions in the antegrade fashion, they cannot cross these lesions using various techniques. Now, you may say that they may not have been as experienced. So then I looked at the Leipzig data, and and if you saw the live case this morning from Dr. Schmidt, you know that he's one of the most talented, if not the most talented operator that I have come across. And even in their experience, if you look here, you see that they were 20% of the time they cannot cross these lesions in an antegrade fashion. So we need to have alternative ways of being able to treat these patients. So we wanted to come up with other ways of doing this, but we want to take it to a next level, meaning that can we have our own algorithm, as Subhash was mentioning this morning on the panel, can we have an algorithm of deciding when do you go retrograde? And we decided that we don't want to spend an hour, 2 hours trying different wires, maybe using expensive CTO wires to try CTO devices to cross these lesions. That we would limit our antegrade approach to 10 minutes. We will try for 10 minutes, but quickly, as Dr. Birlakes said in the CTO session, quickly moving on. If this hydrophilic wire doesn't work, we go to CTO wire. If CTO wire doesn't work, we go to 035 wire. So quickly changing our algorithm. And then if that didn't work, we will go retrograde. And we showed that we could take our success rate from lower 60% to about 97, 98%. And we actually, now you can see that this kind of algorithm can also be applied to the tibial vessels. And in tibials is even more important because the disease is extensive. There are a number of tibials that are involved. There is extensive calcification, and this is the work of Dr. Kuraziani that highlights the amount of disease that these patients with critical limb ischemia have. So because of this, we came up with our own algorithm, and we published our algorithm, as you can see here. in 2016, which is based on time. So we have a 10-minute rule, as I mentioned. Try for 10 minutes using various, algorithmic techniques that we have. And if that doesn't work, we then go retrograde. But when you go retrograde, what access point are you going to use? So there are different points. And again, I'm not going to get to a technical part because my colleagues are going to get into details. But you can use the popliteal access or SFA popliteal access. So there's opportunity to do that. And that can be done in a prone or a supine position. But we have moved completely to the supine position. So in the last 5 years, we don't put any patients in a prone position. And this is really how we do it. And again, Dr. Armstrong is going to go into details of how this is done. I just want to highlight the various areas where you can get the access. So this is SFA POP. And why would you get access here? Well, the reason is because, as Dr. Schmidt showed this morning, is because you need support. If to treat this patient, I come from the DP or the PT, I'm going to lose the support that I need. If the SFA is so strongly occluded, so heavily calcified, that I couldn't cross it in an antegrade fashion. There is a reason you failed in the antegrade. So for that reason, we want to be close to the lesion, so we have the support to be able to treat these tough occlusions very rapidly and efficiently. So the other option is to stick the patient directly into the SFA. So that was popliteal. He showed you this morning how he stuck the SFA. You can use the calcification as I've shown you in this panel, and you can look at the different images to try to find out where your needle is, so you can then get in the middle of the artery and be able to get the retrograde access. This is a case we did as live case last year, and I think Dr. Banerjee was the moderator for this case, where we did it from Antegrade-Retrograde, and we opened up the SFA, occluded SFA last year at the MAC Symposium. But sometimes you're dealing with patients like this. There's a 92-year-old. You can see the tortuosity in the aortoiliac. Trying to get a sheet up and over in this patient is a disaster. And this is a patient with CLI, and you can see the PVR with the flat waveforms all across the thigh and the lower leg. And the patient doesn't have a knob, so it's not possible to come in an antegrade fashion, or it would be very challenging, especially in the 92-year-old with heavy calcification. But we saw that the patient had a stent there, so we used the stent. So I've shown you popliteal retrograde. I've shown you native SFA retrograde. Well, now you can get an intra-stent access. So we can access the stent, and this is relatively safe. Again, you need to use orthogonal views to get into the stent, but we can stick the stent, use different views, make sure that our wire is not behind the stent. And once we are sure that the wire is not behind the stent, the wire typically loops like that, we can advance the wire and you can put a support catheter behind it to help us cross it. And now we can use that wire as a rail, because we have a wire coming out of the thigh and we have a wire coming out of the contralateral groin. We have a nice rail. Now I can get a 6 French sheet throughout that tortuosity, whereas before I could not do it. So these are the reasons for getting alternative access. That's why we need to be able to do these things. The other kind of access is now going down is the tibial access. Again, a lot of people say, well, I don't need to get tibial access because I get pedal access. Well, it may work for majority of the cases, but in some cases where you need the support and you need the large devices to be able to cross the SFA, you need to be able to know how to get that. So this is anterior tibial access, and my colleague, Dr. Art Lee, is going to discuss the techniques both by fluoroscopy and ultrasound to do this. The other option, which is now becoming more common, and Dr. Lee actually let me borrow this slide, you can see that you can get even antegrade tibial access. So we always talk about retrograde tibial, retrograde pedal, but there are situations, and I've done this myself a couple times, that you can actually do antegrade access, and you're right there. These are typically for cases where you're trying to get around the pedal arch. You cannot find something in the foot to get access to, so there is no retrograde access capability, either from the digital or the pedal arteries. In this situation, if you have a vessel more proximally, you can get antegrade access and come down and do your work. And then lastly, there is the famous Dr. Manzi. We can be talking about retrograde access and not discuss his work, is the transmetatarsal access, so getting access in the digital arteries, which is amazing, honestly, that, for us is really getting that wire in that lumen and then being able to externalize the wire and then treat. So anything you can find to be able to get your wire into and then externalize, and now you can treat from the top, I think is something that we should be able to understand and hopefully be able to master. So with that, I'm going to stop. I had a case. Not going to go over that, but I want to highlight one other thing. I have 18 seconds. Is that you don't want to spend an hour going antegrade, retrograde, transmetatarsal, pedal, and not be able to get the wires to meet each other. So you really need to be familiar with the cart, reverse cart, parallel balloon, and facilitated reentry technique. And we showed this in this work that we did in circulation. If you're interested, you can look at the technique. I think most of you know it. A lot of it comes from coronary. But these techniques you need to know like the back of your hand, because you don't want to spend significant time and then not be able to have the wires get luminal and meet each other so that you can treat the patient. Thank you very much.